You can share, sir.
Yeah, please share, doctor.
Is it seen?
It's coming up, doctor.
Coming up?
Yeah.
Is it? I can't.
No, it is not there.
Where is it here? I can't see.
No, it just came up and when his name came forward. That's the first thing, doctor. That happens. Doctor, please share again.
Yeah, I'm trying to share.
No, it's not visible.
Not happening. I don't know, something wrong.
You're on which? You're on phone or you're on laptop, sir?
No, I'm on my
Ah,
Apple Air.
Apple is always a problem.
Dr. Arun has shared his screen, doctor.
Yes, yes, yes.
Dr. Arun, you are sharing the screen?
Yeah, yeah. Arun,
Okay.
yeah, you can run through and then exit. No problem.
Fine.
Yeah, it's moving through. Not a problem.
So may I share now?
Yeah, please.
Yes.
Please, Dr. Pratap.
I hope it is visible.
It's just coming up, doctor. It's showing you have shared the screen. It's coming up.
No,
Yeah,
on my side, it's visible.
Yeah, it's visible, doctor. You can just slide through. Yeah.
Fine.
Yes, doctor. It's
Okay.
fine. Totally fine.
Okay.
I'll just buzz. Dr. Faraz has to join. Dr. Shekhar, meanwhile.
Get joined and exited, so it should not be a problem.
He just asked me to just give him a call. I'm just ringing him.
Yeah, I'm there.
Oh, doctor is there. Sorry.
I'm there. I am on mute.
Welcome,
mode.
doctor.
So yeah, thank you.
Doctor, you have your slide deck, doctor. You will be presenting yourself, right? We have a backup.
I will do my sphere. Yeah, no problem.
If you can just share it once before the start, just to ensure that all are in place. Dr. Shekhar, if you are having a problem, we will share the slide for you.
No, it's not opening at all.
Okay. So
Where do we? Here I don't see any share. Somebody else is doing.
yeah, Dr. Shekhar is trying to do that.
Okay. Yeah.
He's trying to share.
Is it okay now?
Your face is coming up, doctor. Your slides are not coming up.
And it's not going to happen. Somebody has to help me out.
Okay. Jibak, can you just get up, doctor?
Yes, sir. I'll do that.
Just get his slides on for a minute. We'll just see if everything is fine. And then Dr. Faraz can then, just 8 o'clock. We'll just start in a minute.
Yeah, 1 second.
So just to everybody, doctor, what we do is we'll just have a quick 30-second light lamping video which will come up. Then I'll be introducing Dr. Manohar. And then thereon Dr. Manohar moderates throughout. The individual CVs come up and up to you all to share the slides. And if in between any hassles are there in sharing the slides, we'll just help you in sharing the slides. There it goes. And anything you can always WhatsApp me. I've just WhatsApped you. Any issue or anything, then we can connect that way. And just to share a heads up, we have 7,000 plus registrations for this webinar, doctor. Thank you. It speaks a lot on that, and we are hoping for a great webinar, doctor.
Very good. Congratulations.
Generally, these I was also stunned, and honestly, I didn't believe when they were saying about those numbers. But I've seen whenever they do the webinars, it will be class apart. So I would like to thank all of you, my dear friends and panelists. Because of you people only, we're making few records here.
So we can see many records behind you, Manohar bhai. They are hanging on the wall.
Yeah.
These are from India only or from across the globe? 7,000 registrations.
You can see now, sir?
Yeah, we can
Yeah.
see Dr. Shekhar's slide.
Yeah.
So
I'll
Dr.
just
Shekhar will present for you, and you can tell us. So can we start the webinar, doctor?
Yes.
Are you all set in?
Yes, definitely.
So Dr. Shekhar will be sharing your slides. So Jibak, the light lamping immediately. I'm starting the webinar. Let's not waste any time. And then
I don't see still that share button here.
Now, doctor, now you'll be able to see.
No, I don't see still the share button.
Doctor, there's a green button down, if you can see.
Yeah,
With an arrow.
No,
Right on the right upper hand or lower down.
Maybe you
okay,
can.
I got it now. Yeah, I got it now.
Yeah.
It came. It came.
Yeah. So Jibak.
Yeah.
All ready?
Yes, sir.
Already
Arun,
3
they're
minutes
making it
past
live now.
8. Yeah.
3, 2, 1.
Yeah, we are going off screen, doctor. Yep.
1 second, sir.
Good evening, everyone. So I welcome everyone, one and all, for this webinar. And it's very heartening to know that we have a galaxy of speakers and an ocean of attendance for this all important topic where we look at a mineral which is very important, often overlooked, and many times it is gaining a lot of momentum and importance in the current era. So to speak on various aspects, we have lined up series of speakers who will enlighten us on magnesium, which is involved in more than 300 enzymatic reactions in the body. Very important entity when we talk about diabetes, hypertension, atherosclerotic cardiovascular disease. So today's program will bring together all of the experts who address various aspects of magnesium, and I hope it will be very fruitful and enlightening. And I'm Dr. Manohar. I'm the lead consultant at Sparsh Hospital, Hennur, and I'll be moderating the topic. For want of time and repetitiveness, somehow nowadays I don't like being introduced in a big manner, so I started it off. My apologies to the organizer if they have felt bad. So if that is okay, and if I'm getting a nod from our organizers,
Absolutely. Thank you and welcome, Dr. Manohar. We thank you and the entire expert speakers on panel today. We wish to be part of this science and evidence forwarding journey. And as you said, without losing much time, we can get on to the webinar. So please take over, Doctor. Thank you.
so we will deal with this topic in small subheadings so that it becomes very impactful. And to make matters clear and understand, we have very knowledgeable speakers. And who better than our guru, Dr. M.A. Shekhar, to start this webinar? Sir will be addressing as a keynote speaker on subclinical magnesium deficiency, an under-recognized and under-treated condition. Beyond Sir's credentials, which are very, very enormous, Sir was a former Vice Chancellor of Adi Chunchanagiri University, former Director of Karnataka Institute of Endocrinology and Research, And he really gave directions there, and it is what it is now, truly because of his contributions. And is a member governing council of JSS Medical College, Mysore, and much more. And many of us throughout the country, especially those from Karnataka, sir has been a guiding force to us. And beyond his credentials, he's very impeccable, smartly dressed, and he translates complex science into simple insights. So that's what sets him apart from many of us. So over to Dr. M.A. Shekhar. He will give us a bird's eye view and glimpse about magnesium. Meanwhile, our other panelists will be there, and I will come to their introduction as they start speaking. Over to Dr. M.A. Shekhar, sir. Sir, you are muted. You are muted.
Okay, thank you, Manohar, and thank you, Arvind, for this opportunity. And all the astute listeners for the day. I was given to understand 7,000 plus people. I'm sweating. Though it's very cool in Mysore, I'm sweating thinking about 7,000, 2 years listening to me. I'm a little bit scared about what I should do. But let's jump directly into the fringe knowledge medicine. We do not talk much about trace elements. We do not talk much about the so-called small molecules, extremely small elements in the body which can do a lot of work, as Manohar has just said, 300 odd activities. So what I thought, when I have that four extraordinary people who are going to talk in a very clear manner about what magnesium does, what happens if there is no magnesium. I'm not going to touch much upon the so-called hypomagnesemia. Let me give you, the astute listeners, simple concept. Go back, please. Yeah, this is it. Okay. I'm a very simple man. I'm from Mysore. Next, please. Trace elements. This is what I want to tell you in the next 10-15 minutes. I will not talk to you about the in-depth knowledge of hypomagnesemia or hypermagnesemia for that matter. We have my astute 4 doctors who are going to talk much about it. Let me tell you, every time we come across a phrase, we invariably as doctors tend to put in doctoral ideas, engineers, engineering ideas, basic scientists. So I thought I would start my talk with this. The exact definition depends on the field of science. So trace element for a doctor is different, for a geologist is different, for an analytical chemistry is different, but all of them agree it's about 100 parts per million, ppm, whatever you want to call it as, less than 100 parts per million that measures in the atomic count, and same thing 1% in biochemistry, and 1,000 parts per million or 0.1% of rock composition. So across the scientific people, what is trace element? It is a very minute element that is going to do havoc or that's going to save a life according to the science part of it. Next, please. Please, a consultant is someone who takes a subject you understand and makes it sound confusing. So today, you can make out, deliberately I've said an consultant, which is again not English, it should be a consultant. So I already started confusing you with the language. And it's a simple subject that we should understand because very little is required to live. Very little element is required to live happily and healthily. So let me not confuse you according to this slide. Next, please. So this is it. Any chemical element present in the human body in very small amounts, usually 0.1% by volume. Let me tell you in front, it is around or less than 100 milligrams per day. 100 milligrams per day. You can imagine. 100 milligrams, diabetologist, very happy with fasting blood glucose. If you have less than that, you are healthy with trace elements. And these are the examples. We'll not go there. Next, please. But what's important is there are 3 types of trace elements that are required. Nutritionally essential. They are very essential for our health. Probably essential and potentially toxic. Even in lower levels, they can be potentially toxic. If they go beyond certain level, they become toxic. So there are three types of trace elements: nutritionally essential, probably essential, and toxic. We have to only look at nutritionally essential today. But let me tell you, the astute listeners today, please read about potentially toxic trace elements, because unless there is a supplement, nutrition will not give only one trace element. It is invariably a combination. Keep this in mind. Nutrition, supplement. This is where we have to make the dichotomy. We'll see. According to science that I have just garnered, approximately 29 different types in the human body, but it is still growing. We really do not know. If you look at the periodic table, there are so many elements. We do not know how many of them are really required, but it is climbing. As on date, it is 29 trace elements. Next, please. Micronutrients is the other word that we should use instead of trace elements. It contributes to vital bodily function. I'm not going to talk more about it, but human body cannot naturally synthesize these elements. You remember essential amino acids and fatty acids, EFA and EAA. Similar to that, micronutrients, especially the trace element part, we cannot synthesize, even though there are what I call as raw materials we cannot synthesize. So you are exactly dependent on either diet or nutrition or supplements. The first step you have to take, very little you need to keep your health, but it is essential. Second one, the only way you get it is either through your diet and nutrition or through supplementation. And excess consumption, I've already told you, can be potentially toxic. It is away from our discussion today. Maybe some of you can ask me questions. If I know, I will answer. Next, please. Classification. You really need to look at this. When I was a postgraduate, I was given to understand you classify your problem, you can do a better job for whatever learning you are doing. WHO has classified it as essential, probably essential, and potentially toxic. I've already told. Let me not read about that. WHO has classified 19. I have told you 29. There will be differences of opinion like this. Next. But what's important when we come to either nutrients or elements is Friedman's categorical classification. There are 5. Group 1 is macromolecules. You all know carbohydrates, fats, and proteins, etc., etc. Basically, the element is carbon, hydrogen, oxygen, and nitrogen. Group 2 is nutritionally important minerals, which is above 100 milligrams, called as macronutrients, sodium, potassium, etc., etc. Next, please. Group 3 is essential trace elements around 100 and below. You know, copper, iron, zinc, chromium, cobalt, iodine, molybdenum, and selenium. Group 4. Next. Additional trace elements, we will not look at it. You remember cadmium, silica, and aluminum. You know the story about the health and disease that havoc that can create. Keep this in mind. And not essential, and their function are known. There are many, like small amount of gold from Ayurveda, and even lead and mercury. You remember mercury was the first diuretic that they were trying to use, but it was killing the kidney. Got it? Now, 1, 2, 3, 4, 5, which is there. Did you see magnesium anywhere? You did not.
Yes, sir.
You
Group
saw?
2. Group 2.
Group 2 you saw?
Yes, sir.
Very good. Next, please. So, what is group 2? Macronutrient. Very, very important. So, I am talking to you about trace elements less than 100 milligrams of magnesium, magnanimous element, is a macronutrient. Now, diagnosis. How do you diagnose trace element deficiency? Subclinical magnesium activity or hypomagnesemia we're going to talk about, subclinical or whatever. You need to know, unlike any of the so-called parameters that you can easily pick up by many of the biochemical tests, they are very difficult. It's literally very difficult unless you're extremely careful about that. Next, please. There are so many. Next. Go on. Next. So you can imagine there are multiple tests available. None of them with confidence can make a diagnosis of deficiency. This is the next step you have to understand. Next, please. We'll come to magnesium. So trace elements, I have given you an idea. The 5 groups that you need to know. Magnesium is not in the micronutrient or trace element group. It is a essential macronutrient. That's all the initiation that we have to do. But the atomic number is 12. These are all something that I just wrote. Body contains approximately 24 to 26 grams. Can you imagine? It's just about 25 grams. If it's below 24, you're looking at subclinical hypomagnesemia. If a gram or just 1.5 grams, which is not there, you can't even imagine 1.5 grams. You're going into magnesium deficiency. And the fundamental role, as Dr. Manohar beautifully put, more than 300 enzymatic reactions. My dear friends, can you imagine any other element or any other, whatever we are talking about, which has such a magnanimous activity, more than 300 enzymatic activity? This is what you have to remember after we finish with the webinar today. It's a very essential element, a macronutrient, which is very little per day, and your body does not contain huge amount, not 24% or for 15 or 20 kgs of fat, etc. like that. Please understand this. Serves as a cofactor for so many activities. Let me not go there. As I said, 300 enzymatic reactions. You talk about carbohydrate metabolism, protein metabolism, fat metabolism, cellular energy, mitochondrial activity, fantastic. I would like to, anyway, let me talk in a little bit later manner. Next, please. Look at this, just to impress upon you that I also have done my due diligence of getting into all this activity. I'm not going to talk about it because I don't know what is CNNM3, SLC4A1, God bless you. But what I want to tell you is it's very, very important. mTOR you keep in mind for proliferation, DNA polymerase, RNA polymerase. In other words, mitochondrial activity, the cellular activity, extracellular, intracellular, and nuclear activity. Magnesium is a very important cofactor. At what level? Very little, extremely little. How do you get it? Either diet or by supplement. Next, please. Next one. Yeah, I'm not going to talk. This is it. You really have to look. Daily intake around 360 milligrams. Out of that, 120 is absorbed. Fecal output is 260 milligrams. Blood compartment, very little. It is more in the bones. That's all you have to know. In other words, magnesium is an essentially intracellular element, like potassium, which is not that much. But magnesium, much lower than potassium, is an essentially intracellular element, not extracellular. What does it translate into? If it's not extracellular, it's not going to be really significant in the vascular compartment. That's it. That's all you have to know. Next, please. Yeah, this is magnesium level. I've already told you 60% in the bones, 30% in intracellular compartment, and 1% extracellular compartment. Ionized magnesium is 64% of extracellular magnesium, which is supposed to be in the vascular and interstitial compartment. It lacks stores in the setting of hypomagnesemia. It's called an orphan electrolyte. Keep this in mind. Skeletal system has the ability to provide 30% of magnesium stores in setting of hypomagnesemia. So imagine you are not talking about osteopenia, osteoporosis, whatever osteo you want to talk about. When you get into hypomagnesemia level, what saves you? It's the skeletal system. Keep this in mind. But what happens? You all know, my astute colleagues will be talking more about it, clinical features. Next, please. That's it. 4.5 milligram per kg per day of milligram is recommended in the diet. It just translates into around 350 to 400 milligrams per day. So it's not a micronutrient. You need 350 to 400 milligrams. ECF 1%, everything is, repeated activity. All you have to know is, if you want to search for magnesium, please don't waste your time in the ECF compartment. It has to be intracellular. That's why it becomes extremely difficult to know how much of magnesium you have. You can't get into the bone or into the muscles and see. And there are absolutely no tests, biochemical tests, to find out what is the intracellular or bone magnesium activity. Next, please. Next. Yeah, one slide before, so that I will give one slide before, please. One slide before. Yeah. Inadequate intracellular magnesium. I'm not talking about extracellular at all. We have to focus on intracellular magnesium. How do you get it? Only by supplementing it for a longer period, not for 3 days or 4 days. Magnesium supplementation orally for a longer period is going to improve intracellular magnesium. This is another learning you have to have. And inadequate intracellular, CVD and diabetes. Disrupt insulin signaling, leading to insulin resistance, and CVD by arterial stiffness, heightening the risk of thrombosis, platelet hyper, all these things they are going to talk about it. But what is important, if you have good amount of intracellular magnesium, forget about your, cholesterol, all those funny things which are so-called easily visible risk factors. This is also a very important risk factor. Everything is normal, but magnesium is not doing well. Arterial stiffness, blood pressure never drops. You remember that. When you have resistant hypertension, think of magnesium in one of the possibilities. There are many other things. When your diabetic shows insulin resistance features, even though they are not fat, think of magnesium. Where? Intracellular magnesium. Next, please. Common deficiency syndrome, muscle cramps, tremors, chronic fatigue, weakness, irritability, anxiety, insomnia, irregular heartbeat. Out of which people think irregular heartbeat, oh, I drank 2 cups of coffee more, probably I exercised more and all that. Without any apparent reason, if somebody says, I have missed beats, doctor, please open up your mind for magnesium deficiency. And hypermagnesemia is rare, we will not talk about it. But I would tell you, you remember night cramps in older people. Night cramps in older people. We think in terms of all those funny things. Give them calcium, give them that, take out statins, that, this and all that. But please put them on magnesium supplementation. It probably will help them. Next, please. I'm not going to bore you. You can share these slides. If I have to explain this slide, it will take me another 30 minutes. These are the probable problems of hypomagnesemia. Next, please. The last one is subclinical magnesium deficiency, or SMD. Is a state where total body magnesium is low, but serum magnesium level remains within normal laboratory range. You got it, ladies and gentlemen? You look for magnesium in the serum, it is almost normal. But the intracellular magnesium is going to be down. So be extremely careful. You should have heightened perception of picking up subclinical magnesium deficiency by these vague symptoms in your patient. Doctor, my blood sugar is okay. Blood pressure is not coming down. Doctor, I am very strict with my insulin and this thing. Still, my blood sugars keep up and down. One of the reasons, keep this in mind. Early signs of magnesium, I have already told you: weakness, loss of appetite, fatigue, nausea, vomiting. They are all extremely vague, but keep your mind open to look at this in a well-controlled patient who is sitting in front of you, talking about these vague symptoms to you. But what did I tell you? Irregular heart rhythm, ectopics. You should be careful. Next, please. Metabolic effects, cardiac effects, neuromuscular and CNS effects, inflammation and oxidative stress. This is the theory. I'm not going to talk much about it because my, doctors who are going to talk next would be talking more about that. But keep this in mind, subclinical magnesium deficiency is extremely difficult to pick up by biochemical tests. You should open your mind for the suggestion the patient is trying to tell you, doctor, even with these things, I still have these vague symptoms. What are the effects? Metabolic, cardiac, neuromuscular, CNS, and inflammatory, oxidative stress. Keep this in mind. Next, please. Lastly, last two slides. This is the so-called requirement per day. You can imagine, older the person, they need a little bit more, a little bit high. This male and female, even in pregnancy. So pregnant women or lactating women are similar to a male, but this is only for just keeping your mind. I told you per day you need 350 to 400 milligrams as a replacement. If it's 6 months, if there are pediatricians, 30 milligrams. I put an asterisk, adequate intake. Even whatever food the child is taking or the infant is taking, it is good enough. It takes care of that up to 12 months, up to 1 year. If there are seizures in 1 year or an infant, if you are suspecting magnesium, there should be something serious. Keep in mind. Next, please. About magnesium-rich foods, I told you only two sources. One is diet and nutrition, another is supplementation. I'll talk about this and stop. Magnesium-rich foods, millets, ragi, bajra, jowar, legumes, all the legumes that we eat, nuts, almonds is the best source, seeds, pumpkin, sesame, and green leafy vegetables, spinach, methi, and chaulai. Methi, please allow your diabetics to eat methi. They are very happy. Okay, so keep this in mind. Magnesium-rich foods, I have deliberately not put how much they give, but if you put millets, legumes, and leafy vegetables along with some nuts, your job is done. But if they cannot eat all these things in a big way, you have to go for something. How? You need 400 milligrams. I've already told you about this. Even dark chocolate is supposed to give you significant, but please don't confuse your diabetic patient. Please eat dark chocolate. I don't do that, please. Or if you cannot give all these foods in a regular manner, or if the patient cannot take it, you have no other choice. Next, please. To go for oral supplementation. Okay? Next. Common magnesium forms. I was surprised. I knew only 3 or 4. Citrate, glycinate, bisglycinate, malate, L-threonate. Next. Oxide, chloride, taurate, sulfate. Go back one slide. Go back one slide. One slide. You can know citrate, well absorbed. No. Next, please.
Yeah.
Well absorbed, poorly absorbed, inexpensive. All these funny things happen. So you have to look into your so-called prescription, which magnesium salt you're trying to give as a supplement. I leave it here. Next, please. Finally, MMMHH. The days of acronym. Next, please. Magnesium matters in maintenance of human health. That is my final statement. Magnesium matters in maintenance of human health. How? Either dietary supplement or an oral supplement, whichever you are thinking of. Keep this in mind. Why? It is very essential macronutrient to keep cardiovascular health, to keep diabetes, insulin resistance at a check, and also inflammatory process at a check. At what level? Very little level. All you have to do is give them 300 to 400 milligrams per day. That is enough. But another rider is for a longer period, not just for 3, 4, 7 days. Next, please. Final. Harry S. Truman, you all remember? One of the tough presidents of United States, not like the present tough United States president. He said, if you can't convince them, confuse them. I hope I have convinced you. I have not confused you. Thank you very much.
Excellent, sir. As always, you have always convinced us more than confused us. And any confusion, we come first to you for clarity. So what sir says is think magnesium, whether it is vague symptoms to arrhythmias, whether it is diabetes, hypertension, vitamin D, and so on. And it also reminds me of the Harrison's quote on subclinical magnesium deficiency is very common and we should actually look for it and treat it. And sir rightly said that it is an intracellular ion. So even if you do a serum levels, we miss a lot of subclinical magnesium deficiency. And of course, he clarified us that magnesium is an essential macronutrient, not just a micronutrient. Thank you very much.
One clinic referral I forgot to tell.
Yes, sir.
Please, for heaven's sake, even every time you give calcium supplement, see to it that you supplement magnesium. For calcium to act effectively, properly, you need magnesium.
Yes, same holds good with vitamin D, and I think our next speakers will talk on that. Excellent. I hope you can stay along and help us understand some things better. So next we'll move on to our next panelist, Dr. Pratap P. Jetwani, who will tell us about magnesium's prevalence and relevance. Now we have learned a bit about magnesium, and now why is it important? What is the prevalence and what is the relevance of it? Dr. Pratap Jetwani is from Rajkot and is a rich man, not just being a Gujarati there, but he is also the current treasurer of RSSDA National Chapter. And he has done a lot of work, especially publications wise, and his case files along with his colleague Dr. N.K. Singh's are very much appreciated. Past associate editor of Indian Diabetes Educator Journal, and many more to come. So without much ado, I would request Dr. Pratap Jayatwani to straight go into the topic and enlighten us why is it relevant to know about it, and how much is the prevalence of hypomagnesemia.
Thank you, Dr. Manohar, for kind introduction and for involving in this beautiful seminar on trace elements, particularly magnesium. I hope my slide is visible.
It's visible.
Okay, fine. So after an excellent talk by the teacher of teachers, Professor Sekhar, highlighting the importance of magnesium and why it is important to learn about magnesium, I will be talking about hypomagnesemia, prevalence and relevance. So physiological profile already touched upon. It is the fourth most abundant cation in the body and the second most abundant cation intracellular fluid, serves as a cofactor for about 600 cellular enzymes, including multiple which are enumerated here. It plays critical role in protein nucleic acid synthesis and various ligand receptor interactions, where it exerts a major biological influence, and it is important very much for the parathyroid hormone release from the gland, plays an important role in the calcium homeostasis also. In humans, more than 50% is in the bone, already highlighted by Professor Sekhar, and less than 50% is in the muscle and other soft tissues, and it is purely an intracellular, what we can say is an element. Hypomagnesemia is defined as a serum magnesium concentration when it goes below 0.7 millimole per liter or goes below 1.7 milligram per deciliter, then it is being termed as hypomagnesemia. And when it goes below less than 0.5 millimole per liter, then it is generally termed as severe hypomagnesemia. It reflects systemic magnesium depletion and is associated with significant neuromuscular, cardiovascular, and metabolic consequences that I will touch upon in my subsequent slides. But important thing is already highlighted by my previous speaker, that the serum magnesium may be normal in the presence of total body magnesium depletion, which termed as subclinical magnesium deficiency, and this has implications for clinical practice, and you have to keep this in mind. Prevalence, if we see across various clinical settings, it is generally underdiagnosed due to predominantly intracellular distribution, as already highlighted. Outpatient or general population, the data are variable, ranging from 2% to 15%. Hospitalized patients, it is up to 20%. In critical care settings, it is up to 65%. And with alcohol use disorder, it is around 30 to 80%. So alcoholism, critical care illness. These are the two factors which are associated with increased prevalence of hypomagnesemia because of the multiple factors. This is the Harrison's textbook of internal medicine, various causes of hypomagnesemia, and it is a very detailed slide, but mainly it is either because of impaired absorption from the intestine or increased loss from the intestine or impaired renal tubular reabsorption, which results in increased renal excretion, which can be either because of genetic magnesium wasting syndromes, prominent to say is Gentleman syndrome, drugs and toxins, or various other causes. And fourth is rapid shifts from extracellular fluid, particularly recovery from decay or correction of respiratory acidosis or refeeding syndrome. These are the things where intracellular redistribution occurs, and this may result in the development of hypomagnesemia. So, in nutshell, I can say there are three main causes for hypomagnesemia. Either it is because of GI losses in the form of chronic diarrhea, vomiting, or malabsorption, and PPI use is one of the common reasons for hypomagnesemia. Very rampant use of PPI for longer periods can interfere with absorption and can result in hypomagnesemia. Renal losses, particularly diuretics, either loop or thiazide, Gentleman syndrome, I have already told, and osmotic diuresis in any condition can result in increased renal losses and contribute to hypomagnesemia. And third one is variety of drugs. They can interfere with either absorption or they can promote excretion or various other aspects. Few drugs to name is amphotericin B, cisplatin, aminoglycosides, cyclosporin, and tacrolimus. So this calcineurin inhibitors, aminoglycosides, cisplatin-based therapies, and amphotericin B, these are the few prominent drugs which can result in hypomagnesemia. And this the physicians have to keep in mind. If we see the impact, the prominent impact occurs on the cardiovascular system because magnesium is critical for cardiac electrophysiology and for vascular tone regulation. So, as already talked upon, that arrhythmias, atrial fibrillation, tosa de pointis, they are increased. There will be increased risk of this when there is hypomagnesemia, particularly severe hypomagnesemia. Vascular, there will be endothelial dysfunction and hypertension, and refractory hypokalemia is one of the important cofactors with hypomagnesemia, and you must need to correct magnesium in people who are having refractory hypokalemia or hypocalcemia. There is 2 times increased risk of cardiovascular mortality in severe magnesium deficiency, and this is mostly because of the increased risk of arrhythmias. It has got important role in neuromuscular and psychiatric systems. Deficiency results in hyperexcitability, tremors, fasciculations, tetany, psychiatric manifestations in the form of apathy, delirium, confusion, and clinical depression, and seizures. They generally occur in pediatrics or with severe deficiency. Otherwise, tremors, fasciculations, and tetany, they are the common manifestations of hypomagnesemia, with mood disorders, confusion, apathy, and delirium. It has got very important part in metabolic and bone health. Majority of it is stored in the bone. So if there is a low magnesium, then it leads to PTH resistance or reduced secretion, causing refractory hypocalcemia. That one has to keep in mind. So when correcting hypocalcemia, it is must that you take a look upon magnesium also and correct it also. Bone health, there is a direct impact on bone crystal quality and osteoblast activity, and therefore it can result in osteoporosis or diminished bone health. It is crucial for insulin receptor kinase activity and glucose transport control, and therefore if there is a deficiency, then it definitely going to impact your blood glucose levels. So if we see the clinical spectrum of hypomagnesemia, this is a beautiful graphic. The upper part is the symptoms which are related to hypomagnesemia or a magnesium deficit, both of which are potentiated by concomitant hypokalemia as well as hypocalcemia. That is neuromuscular manifestations and cardiac arrhythmia, QT prolongation, atrial fibrillation, and torsades pointis. If we see the lower part, these are the clinical associations with hypomagnesemia. The gray arrows, they indicate a stronger association, whereas the lighter arrows, they indicate there is a probable association. So what are the things which are associated with? Diabetes, that is glucose metabolism, bone fracture or osteoporosis, cardiovascular disease in the form of heart failure, vascular calcification. These are strongly linked with hypomagnesemia or magnesium deficit, kidney function decline, acute or chronic, stroke or cerebrovascular disease, and impaired cellular immunity resulting in infections. There is less supportive evidence, but they are also linked with hypomagnesemia. So this is a nutshell how hypomagnesemia it manifests as far as clinical conditions are concerned. How to diagnose hypomagnesemia? There are battery of tests, but the important one is serum magnesium and ionized magnesium. Serum magnesium is not adequate since less than 0.3% of total body magnesium is found in serum, but it is easy, accessible, and cheap. Ionized magnesium is more accurate, particularly in critically ill patients with rapid change in hemodynamics, and it is not affected by low albumin. And therefore, this can also be used. And then there are other things. If you are suspecting renal wasting, then you have to go for 24 hours excretion in urine or the fractional excretion of magnesium. Then there is magnesium loading test, which identify patients with normomagnesium magnesium deficiency, that is subclinical, and intestinal absorption can be accessed, and indirectly you can access the bone status of magnesium. These are various tests in RBCs and isotopic analysis, which are only for research use. For clinical purpose, it is serum magnesium or ionized magnesium, and in select cases, 24-hour excretion in urine or the fractional excretion of magnesium that will help you understand what is there hypomagnesia and what is the cause for it. So to conclude, I will say always check magnesium. For physicians, that always check magnesium in refractory hypokalemia or hypocalcemia. It is very common, a cofactor in causing multiple problems. PPIs and diuretics, which are used very commonly in clinical practice, they are significant iatrogenic drivers of hypomagnesemia, and you have to keep that in mind. And clinical symptoms, generally, they are non-specific, so you have to maintain a very high index of suspicion in every case where you suspect hypomagnesemia. Subject them to a test and even give them magnesium supplement. That will do more benefit than harm. Thank you for your attention. With that, I hand over to Dr. Manohar.
Thank you very much, sir. Lot of clarity, beautiful slides. I really enjoyed it. And you mentioned how underdiagnosed it is. Caution, please remember, if someone is alcoholic and if they are in the ICU, higher degree of suspicion is needed. It is low because of GI loss, renal loss, or drug induced. And the clinical spectrum, and beautiful, I think I really loved that slide. Like, it has a lot of associations in which it should be more thought of, is what we need to look at it. And I hope you can stay with us for some time, or if there is any questions pertaining to his talk, we can ask. I don't know if the organizers are okay with that.
Dr. Manohar, you can answer.
Yeah, definitely.
Yeah,
absolutely.
Professor Sekar is there, you can answer.
Definitely, we'll do that.
Okay.
It was very, very enlightening talk. After this, we'll move on to another talk from another good speaker and friend of mine. So we're all metabolic physicians, and obesity and diabetes are the two important things what we look at. And to understand the relevance of magnesium in diabetes and pre-diabetes, we have our good friend Faraz, endocrinologist from Hyderabad, and lot of accolades. Recently, also, he's been honored with a lot of prestigious awards. If I start naming it, the seminar won't be sufficient enough. A great person involved in research, and also a special area of interest is millets. A lot of emphasis on lifestyle, and he has received various fellowships and a lot of publications in very reputed journals. So over to my friend Faraz, who will enlighten the utility of magnesium, how we have to see in the context of diabetes and pre-diabetes.
Thank you, Manohar, for that warm introduction. And then I think my job is made very, very easy. I mean, the way this 2 sessions have went, it's just amazing. I think I have learned many things about magnesium. It is all of us have learned something about magnesium. We always felt good that it's just a simple element. I think we never used to concentrate on magnesium. But just let me tell you that maybe 5, 6 years back, my mom was diagnosed with restless leg syndrome. We were treating her with everything. Still, it was not getting controlled. We did the magnesium levels at that time. It was normal, but one of my friends was very pertinent, being a critical care physician and a neurologist. He was like, no, 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 no. I think that it is subclinical. And then we were like, were you telling to us? And then he was like, okay, we'll give a therapeutic trial. And as I love the way when Dr. Shekhar said for a longer period. So I think we started it 15 days, 20 days, 1 month. And then I was like, what nonsense, this is not working. And he's like, let's continue. And then believe me, that had done wonders. So I think that is where in years now, we all understand that magnesium has a role in most of the metabolism. And then as I rightly said, my friend Manohar was talking that we all are metabolic physicians now. We are rebranding ourselves as metabolic physicians. So we just cannot I move ahead if we do not talk about the metabolic disorders, mainly I think pre-diabetes and diabetes, which I have been asked to. So again, if you will see, we heard about hypertension, we heard about cardiovascular disease, but I think these are few slides which will open up your eyes. If not, it will at least wake you up from your sleep with voice of mine. Because if you will see, magnesium deficiency is more common in patients with diabetes, with poor glycemic control, longer disease duration, and patients who have micro or macrovascular complications. So if you will see the systemic review and meta-analysis, I think we all are evidence-based medicine persons here. It said the prevalence of hypomagnesemia was 32% with higher rates in Asia. It is amazing. I think we all knew that it is there, but as high as 32% is eye-opening. An Indian study found hypomagnesemia in the range of 57% with higher fasting and postprandial blood glucose controls. I think we were talking about chromium a few years back, that maybe that is one parameter with diabetes. But now you see, I think we have another important parameter like magnesium. So magnesium is a cofactor in glucose transport, insulin sensitivity, and then in acting on the insulin resistance pathway as well. Again, if you will see, I have to talk about research because that is where my most of work moves around. Meta-analysis of 10 observational studies involving around 3,000 patients showed that circulating magnesium levels in people with pre-diabetes were lower than healthy controls. So now it is telling us that whenever we are dealing with pre-diabetes patients, we're talking about lifestyle management, we talk so much about diet. So I think it is very important that we start looking at magnesium in these patients at that stage and help them to overcome this deficiency so that we at least prevent them for the progression from pre-diabetes to diabetes, where magnesium a role might also be there. So you will see again, there was a lot of talk on the intracellular magnesium. So again, you will see the intracellular magnesium concentration result in defective tyrosine kinase activity. There is receptor impairment of insulin action, and then that worsens the insulin resistance and adds on to the pre-diabetes. So again, my friend was quoting about Harrison. My colleagues were talking about Harrison. We as physicians we just cannot leave this book because I think all of us are preach followers of this book. So Harrison, the 21st edition, it says Hypomagnesemia can be because of decreased dietary intake, oral anti-diabetic medication. So I think when we were talking about metformin, we said chronic usage can lead to B12 deficiency. This is an eye-opener that even you have to look for magnesium as well, sulfonylureas and glitazone. So these 2 or 3 commonly used drugs for a longer period of time can lead to reduction in magnesium levels. So you have to be very clinically vigilant. Enhanced renal magnesium loss, osmotic diuresis. So magnesium deficiency leads to a poor glycemic control, and then it is a vicious circle which your patient goes through and then develops uncontrolled diabetes and then complications. Which came first? Again, there is the question whether the chicken or the egg. But here again, similarly, you see it's the vicious cycle. Low magnesium levels worsen the insulin resistance. Insulin resistance again worsens the hypomagnesemia. So again, this looks to be a very clinical and a busy slide. What I would like to get your attention is simple. As a physician, just remember that magnesium and insulin secretion from pancreatic beta cells that gets affected in various ways. So you will see magnesium deficiency affects the glucokinase, the glycolysis, inhibits the beta cell depolarization, and many other parameters. What it does as a clinician, compromised insulin secretion. So I think it is not only the insulin resistance, but it is also playing with insulin secretion as well. So this should alarm you that this is not going to help you to improve the insulin resistance, but it would also help you to improve the insulin secretion as well. Again, just simple, you can see a lot of magnesium there. Magnesium deficiency leads to beta cell dysfunction, insulin resistance affecting the intracellular levels, worsening the hyperglycemia. I think that is the gist of that slide. So magnesium deficiency, you will see, impairs the glucose uptake in muscle and adipose tissue. So I think this is one of the reasons why it is adding on to the peripheral insulin resistance, which is a very important parameter when we're talking about diabetes. This results in elevated glucose, and then it manifests in the form of magnesium deficiency. So when it is metabolic, you can see either in the form of insulin resistance, beta cell dysfunction, glucose intolerance, increased risk of diabetes, dyslipidemias, weight gain, disorders of vitamin D metabolism. I think Manohar spoke on that point that calcium, vitamin D, and magnesium, I think now all go hand in hand. And when it comes to cardiovascular, I think my senior colleagues have already spoken about the ill effects of reduction in magnesium levels. Influence of magnesium on glucose metabolism. So here again, you see it acts on the hexokinase, it acts on the PFK1. Again, this used to be our slide when we were in biochemistry. We do not love it anymore. I think as a clinician, we do not like it. But just remember, magnesium is a cofactor for rate limiting enzymes in glycolysis and gluconeogenesis as well. So oral magnesium supplements have been shown to improve the fasting and postprandial levels, improve the insulin sensitivity in hypomagnesemic type 2 diabetic patients. It has shown to decrease the CRP. So that itself says that it is acting on the inflammatory parameters of the metabolism. Pooled analysis of 24 RCTs with 1,300 diabetic individuals revealed that subjects who received magnesium supplementation had significant reduction in fasting sugars, A1C, systolic and diastolic blood pressure. So it is now very, very important. And then you will see it also helped to improve their hypercholesterolemias as well. So this can justify the early use of oral magnesium supplements, potentially aid in slowdown of diabetes and its complications. So before I end, I would like to say that yes, magnesium is a very important part of the metabolism when it comes to pre-diabetes, diabetes, and obesity and metabolism. So it is very important that, yes, we first treat this with lifestyle, improve the nutrition aspect, I think Dr. Manor was talking about millets, and Dr. Shekhar was saying these are rich in magnesium. So I think I would like to highlight that point that yes, increase the intake which your patient needs. If they are not getting improved or they are not showing the clinical benefits, then I think it is very important that you start the patient on a supplementation. So thank you so much for your patient listening. And back to you, Manor.
Excellent, Dr. Faraz. I was also shocked with the statistics you gave. One third of the diabetics, or maybe even half of our diabetics, could be magnesium deficient. And your own personal experience about magnesium must be making you believe much stronger in this entity which we have by far neglected. Any other points you want to say before we move on to our next speaker?
No, I think we are all done, and then we all are waiting for the next speakers, our dear friends, to highlight us more on the other topics.
So, moving on to our next speaker, who will enlighten us on magnesium and what its effects on CVD and hypertension. Good friend of mine again. We all are practicing boring diabetology many of the times from medicine, but he does everything medicine, diabetes, and also rheumatology is his area of interest. And again, a lot of interest in publications and research all the way from Chhattisgarh. Welcome, Dr. Arun Keria, and enlighten us on how magnesium has a say in CVD and in hypertension.
Oh, thank you, Manohar, for making me a part of this program. And I feel honored to be a speaker amongst the galaxy of stars that you have already been able to bring onto this platform together. So, Dr. Shekhar has already given us the brief on how important is magnesium. We've also learned about the challenges of diagnosing magnesium deficiency. We heard the prevalence from Dr. Jethwani sir, and then Faraz told us about its importance in diabetes. So in next few minutes, I would be speaking on the role of magnesium in hypertension and cardiovascular disease. And I think these are the two important sections of our clinical practice, because hypertension is the single most risk factor for stroke. And if you see the CVD, it covers an entire spectrum, right from metabolic syndrome to end-stage cardiac disease. So this has been already spoken that magnesium is often overlooked. And I think from the days of biochemistry, if I remember, we've already been taught that in most of the time, wherever you have to put in a cofactor for an enzyme, put it as magnesium. And that is what is usually correct. So magnesium serves as a cofactor for more than 600 enzymatic reactions. But what is important from my aspect is that it contributes to the regulation of blood pressure. And in the next few slides, I would show how it helps in maintaining the smooth muscle relaxation. The other important point that we need to remember that it is the natural new calcium antagonist, and that is where it also works as one of the important ion for ion transport, thereby regulating vascular tone as well as smooth muscle contraction. The other new thing that I learned was that magnesium has a role in maintaining aldosterone levels, and that is something which is very, very new for me also. And apart from that, it also modulates the sympathetic nervous system, which is again a part of all cardiovascular diseases. So coming to hypomagnesia and hypertension. So magnesium, it affects blood pressure by modulating basically the vascular tone and the sympathetic activity. And it has been implicated as one of the important factors for the management of normotension. Most of the epidemiological studies have demonstrated an inverse correlation between blood pressure and serum magnesium levels. But of course, if you go through all the studies, there will be a lot of heterogeneity, probably because we are still not able to define hypomagnesemia and actually correct identify the patients of hypomagnesemia. So chronic latent magnesium depletion, almost 25% prevalence. And again, the important part is more than 30% of the population have a low magnesium intake. In the field of cardiovascular disease, where diuretics are commonly used, we need to remember that they are one of the nuisance drugs when it comes to maintaining magnesium level, because they actually cause magnesium diuresis. But what is important is that subclinical magnesium deficiency is one of the risk factors for hypertension as well as cardiovascular diseases in the form of arrhythmias, arterial calcifications, heart failure, increased prothrombosis, and still it remains one of the underdiagnosed driver for cardiovascular disease. Definition for deficiency has already been taught. This could be the spectrum of cardiovascular risk associated with hypomagnesemia, starting from simple hypertension to sudden cardiac death. And then we have the entire mechanisms behind the sudden cardiac death in the form of increased platelet aggregation, atherosclerosis, increased thrombosis, and stroke and heart failure. Now, it is important to understand how it maintains the homeostasis of vascular smooth muscle cell. So as already been spoken, that magnesium is not a static ion. It is mainly intracellular, but it moves across the membranes and maintains a balance between important cells like muscular cells, smooth muscle cells, especially the cardiac cells. So magnesium enters the smooth muscle cells via channels, and this is basically maintained by an active uptake. So mitochondria is involved for energy. And there is simultaneously another sodium magnesium exchanger, which maintains magnesium by exchanging it for sodium. And then there are buffer systems, which you've already learned from that skeletal system is one of the most important buffer. And increased intracellular calcium, which occurs in magnesium deficiency, actually leads to hypertension, vasospasm, as well as potential of vasoconstrictor agents. So this is what happens when you have lower magnesium. You have endothelial dysfunction, you have increased catecholamine sensitivity, increased oxidative stress, arterial stiffness, and most important that it leads to hypercalcemia, which leads to both structural as well as functional changes in the blood vessels. And ultimately, it leads to increase in the total peripheral resistance, thereby causing hypertension. So magnesium deficiency, we need to understand that it indirectly leading to basically mitochondrial dysfunction, and there is dysfunction of sodium potassium ATPase, which leads to further depletion of the intracellular potassium. And we have been taught right from MBBS days that whenever you have a patient of resistant hypokalemia, you must think of simultaneous magnesium deficiency. And it is very important to correct magnesium deficiency along with potassium deficiency whenever you have such cases. And that could be one of the important learning lessons that we need to understand in our daily practice. So magnesium deficiency definitely leads to increased response to vasoconstrictors. It causes increased muscle spasm, and thereby it leads to increased peripheral resistance and hypertension. The most important practical challenge that happens in hypertension is that we often use a lot of diuretics. And in fact, in most of the guidelines, you see diuretics are one of the most indicated first-line therapy for hypertension. But what is important that when you have increased renal excretion of magnesium with these diuretics, it is very important to ascertain that the patient takes adequate magnesium either through the diet, or if he's not able to maintain through the diet, then one needs to supplement magnesium throughout the life. Low magnesium is also associated with endothelial dysfunction, and I has already told you that it leads to increased vasoconstriction, thereby increasing the risk of thrombosis and atherosclerosis. Low magnesium itself is a pro-atherogenic phenotype in the endothelial cells. It impairs the release of inducible nitric oxide, thereby causing decreased vasodilatation in patients with CAD. And we already know the importance of inducible nitric oxide, which is very important for vasodilatation. And magnesium also helps in prostacyclin release from the vascular wall. So if you combine this endothelial dysfunction, ultimately magnesium deficiency would lead to atherosclerosis, It also leads to calcification in the tissues as well as in the smooth muscles, and thereby it leads to the pathogenesis of ischemic heart disease. So magnesium deficiency also controls various other ionic channels, and one of the important ionic channel is the sodium potassium ATPase. And whenever you have magnesium deficiency, you will have low ATP production, which leads to higher level of sodium and calcium within the cell, leading to arrhythmias. And these arrhythmias can sometimes be dangerous. In fact, a lot of patients can have simultaneous potassium and magnesium deficiency, leading to dangerous ventricular tachycardias. So magnesium deficiency is definitely another important factor for coronary artery disease, which I've already spoken. The most important reason is the endothelial dysfunction. Also, magnesium deficiency leads to pro-aggregatory and pro-coagulation alterations, which lead to increased thromboxane synthesis, thereby causing platelet activation. And this platelet activation leads to platelet aggregation, causing a lot of thrombus formation. So if you have a patient with widespread thrombosis, if you have a patient with recurrent thrombosis and you're not able to find out a cause, then think of magnesium deficiency or magnesium supplementation. So if we have to summarize the overall mechanisms by which magnesium is involved in cardiovascular diseases and hypertension, you have to remember in all the five categories, that is right from endothelium, where magnesium is important for inducing nitric oxide release. Then at sympathetic nervous system, we need to understand that magnesium increases the sensitivity to vasoconstrictors and lead to increased sympathetic activity. At the level of kidneys, it reduces the reabsorption of potassium, thereby causing potassium wasting, and that potassium wasting leads to magnesium deficiency. At the level of adrenal gland, it leads to increase in aldosterone, which further increases hypertension as well as edema in the body. And at the level of antigen presenting cells, this magnesium deficiency leads to pro-inflammatory cascade, thereby leading to increased inflammatory cytokines. And these inflammatory cytokines are another mechanism by which you have atherosclerosis, because old age, we have been studying since ages that atherosclerosis is nothing but an inflammatory disorder of the blood vessels. So whatever we know today about magnesium is still less. Our knowledge is finite, but ignorance is still infinite. And I think these type of webinars will definitely help us to learn more about the trace elements. So with that, I conclude my session and I hand over back to Dr. Manohar.
Thank you, Dr. Arun. This sort of webinar and people coming in, and you said that your depth of knowledge, you learned a lot and you taught us a lot also. So thanks for that wonderful talk. And I really loved that illustration, what you showed, the five components of the cardiovascular disease, what we are addressing, even about the aldactone, aldosterone. It was also a learning curve for me. Again, arrhythmias, I think we all agree, and refractory hypokalemia, we all agree. But as you rightly pointed out, it could be much more than that. Hypertensives, especially on diuretics, we should always keep our mind open for hypomagnesemia. Thanks a lot. Now we will move on to the last topic. The last was never the least, and we have a shares to deliver the talk, Dr. Sher Singh Daria, a good friend from Rajasthan. A lot of buzz about vitamin D deficiency, but in practice, we see that many people who are taking vitamin D regularly still have not been corrected to other required levels. One of the reasons is it magnesium. That's what he's going to highlight us on. And Dr. Daria is a governing council member of API. A lot of interest in teaching. Is associate professor from Jaipur, and he has also been editor-in-chief for monographs on diabetic foot and many more such initiatives by API and RSSDI. So thank you, and we welcome Dr. Daria to enlighten us on what is the link between vitamin D and magnesium.
At the outset, thank you so much, Dr. Manor, for including me in this webinar. And as we all know that magnesium is something that this is under recognized. Na? It's although shared by Dr. Kedia, it's overlooked, but it's not overlooked. It's underreported till now. And if we talk about the epidemiology of vitamin D, almost I think 99% of Indian population is lacking of vitamin D.
Yeah.
And the one of cause for that vitamin D that may be because of magnesium, because of hypomagnesemia. So let's see. The optimal health benefits of the vitamin D, whether it is endogenous or exogenous, might not be achieved without the adequate presence of magnesium, because at the bioactivity of vitamin D is a magnesium dependent process. Whether it is a transport, conversion, activation, absorption, and action, everywhere the magnesium is cofactor. So that is the reason somebody who is having a vitamin D deficiency, then we have to look regarding the magnesium also. So the how it acts, because this while magnesium is helping the process including all the absorption utilization of vitamin D, the inadequate vitamin D also affect the magnesium absorption. So this the interconnected. So if there is a vitamin D deficiency, then you may have a magnesium deficiency, and if it is a magnesium, then again. So giving vitamin D alone would use magnesium from body stores and deplete it further. And mainly it comes from the intracellular pool. As we are discussing since last 1 hour, it is mainly intracellular. So this would aggravate or precipitate subclinical magnesium deficiency, where initially Dr. Sekhar sir already told that the SMD, subclinical magnesium deficiency, is a state of intracellular ionic magnesium deficit despite having a normal serum level of total and the ionic magnesium. So if since there is a intracellular ionic magnesium is a key effector for your active vitamin D, that would lead to defect in the vitamin D utilization and the suboptimal therapeutic outcomes, in the addition to resulting in suboptimal vitamin D level. So when the current practice with the high dose of vitamin D without due consideration of the magnesium status, we are giving our all patients, and we are seeing that even after giving the vitamin D, the magnesium from intracellular stores for its activation and pharmacological function, resulting in further depletion. So this is the condition where we used to call it as a SMD. The state of subclinical magnesium deficiency will aggravate. So this lead to defect in vitamin D utilization and suboptimal therapeutic outcomes and vitamin D levels. So continuing using dose of vitamin D additionally in presence of subclinical magnesium deficiency definitely would increase the levels of vitamin D in serum without exerting any therapeutic effects. So the SMD is very critical when the magnesium deficiency symptoms would be superimposed, leading to worsening of symptoms and inadequate vitamin D levels both. So therefore, there is a need to prescribe vitamin D and magnesium altogether. So once if you are giving only vitamin D, then there is a no magnesium, and then it further, because it's having a so much effector or the synthesis activity, so it will lead further to the subclinical magnesium deficiency itself because of the vitamin D. So dysregulation in any of these nutrients can be associated with various disorders like your skeletal abnormalities, cardiovascular disorders, and metabolic syndrome. So it seems that considering magnesium along with vitamin D is a good approach to improve the functions of vitamin D in the body. So again, this is the role of vitamin in here you can see it is a cofactor for everywhere, whether it is a conversion, activation, transport, and pharmacological action of vitamin D3. Starting from here, you can see that from cholesterol, once vitamin D3, then binding of vitamin D, protein binding proteins, then again 25 hydroxylase, all process including the having the importance of the magnesium. Everywhere you can see that magnesium, magnesium, magnesium. So there are a lot of studies also. It's not that it's hypothetical, but according to the National Health and Nutrition Examination Survey since 5 years, and they said that high magnesium intake declines the risk of vitamin D deficiency or insufficiency. Another study where we showed that a significant increase in 25-hydroxy occurs only with the co-supplementation of vitamin D and magnesium. And some other studies also showed that adequate magnesium can keep vitamin D levels within the normal range and prevent vitamin D toxicity. There are another clinical studies where the supplementation of magnesium significantly affected the vitamin D metabolism in participants from the personalized dose regime adjusted for oral dose by the participants. And in that, they seen that the decrease your concentration where the vitamin D was there in the twenty-five to evidence shows that the addition both co-supplementation of vitamin D and magnesium in control of the side effect of vitamin D supplement, including vascular calcification. So shown that the dose of calcitrol alone increased the prevalence of vascular calcification in experimental model. It was used with magnesium, the severity of calcification decreased compared to the control group. So there are a lot of studies. Again, the initial Dr. Sekhar was telling that TR, PM7, SOTR, MOTR. So these all are the basically protein compared with calcitriol and the magnesium. In summary, the magnesium prevents a decrease in TR, PM7 and reduces the severity of vascular calcification and increases the bioavailability of magnesium in the microvascular environments. So then another study where the vitamin D affect magnesium status, the 125 dihydroxy has been shown to stimulate magnesium uptake in intestine also. In that study where the L degree, the effect of vitamin D supplementation and magnesium blood level in patient with type 2 diabetes demonstrated a significant increase in serum magnesium level after taking the 200 IU per day of vitamin D supplementation for the 6 months. And this is again the essential magnesium for optimum vitamin D levels and activity. This was a 12-week randomized control trial which showed that combining the magnesium and vitamin D regime in more effective increasing the serum 25 hydroxy concentration than the vitamin D alone. So if we are combining both vitamin magnesium and vitamin D co-therapy, then there will be definitely increase more in the 125 dihydroxy levels. So, in concluding that all main phase of vitamin D metabolism and therapeutic actions are magnesium dependent. The vitamin D activity enzymes and binding proteins both utilizing magnesium as a cofactor. The serum 125 dihydroxy concentration frequently remains low in patients with magnesium deficiency, even despite giving the adequate vitamin D intake. The vitamin D deficiency frequently coexists with the magnesium deficiency. There are a lot of RCTs who have provides the evidence of how magnesium supplementation affect the vitamin D status and metabolism among those without overt vitamin D deficiency. And additionally, the magnesium independently improves serum vitamin D levels. The recent cohort study concluded that the co-supplementation could be the promising treatment to improve vitamin D status and control the side effect of vitamin D supplementation. So thank you everyone for your patience hearing.
Thank you very much. I think very, very pertinent points. So sometimes we always wondered, isn't it? Why is this person who says that he's taking the vitamin D supplements regularly, but then is not corrected? Possibly we are missing link or missing puzzle piece could be magnesium. Of course, the commonest still would be the compliance, is what I feel. It was lovely. I didn't realize that we have gone past more than an hour and a half almost listening and learning about a very exciting molecule about magnesium. We all started with Dr. M. A. Shekhar sir throwing light on how important of an element it is and highlighting on what it is, a macronutrient. Any further takeaways you want to give us, sir? Especially from what it is to how clinically, where we should start thinking about it. Of course, in the ICU setting, as many of our speakers said, in the treatment of hypokalemia or arrhythmia, we generally definitely keep this in mind. But in other instances, it's almost like a forgotten entity. So, especially in the cold case or in the outpatient management, where all we should think about magnesium and how to supplement and how to get the best out of this to our patients. Shekhar sir.
You want me to interject here?
Yes, sir.
Okay, I would like to tell people there is a phrase called as pinch hitter. I hope you people remember that. It is usually used in baseball in America, and there are different level replacement player, all those funny things. But the highest level of this baseball player is called as pinch hitter. They don't come suddenly, but when they come into the field, they would do a fantastic work. So I'm thinking in biological terms, magnesium is a pinch hitter. You know, it just keeps quiet. Whenever it's needed, it does its job. You name the whole damn thing, whether it is cardiovascular, skeletal muscle, any cell in the body needs magnesium, but it never opens up itself. It just says, I'm here. You want me? I'll come and help you. My reaction.
Dr. Kedia, you want to add something about what is our current understanding and where we can really look in to utilize magnesium for the benefit of our patients? Where are we lacking in many instances? Acute care setting, you really highlighted it very well.
So I'll divide my answer into two parts. As I already said, acute part, always remember magnesium whenever you are handling a patient with hypokalemia. Second, it is very important to take a good history. Most of the patients of hypertension are prescribed thiazide type diuretics, and often these patients complain of fatigue. And we often think that probably fatigue is only due to dehydration or it is just due to diabetic. We forget to check electrolytes. At few centers, people do follow up these patients with sodium and potassium, but magnesium is never done. Usually, if a patient maintains sodium somewhere, potassium somewhere around 3 to 3.5, I would always prefer to add magnesium in such patients. Another important category of patients where you have both hypokalemia along with hypocalcemia, there you should still have a stronger suspicion of hypomagnesemia. So if you have a refractory hypokalemia with hypocalcemia, again add magnesium along with the correction of potassium and calcium. The third important place where magnesium again has a very important role is probably, in our country, we should think of women. Women always come with vague symptoms, and we often label them as, an anxiety, functional, but, fatigue, uh, non-specific pains, especially nocturnal leg pain, cramps. These are the places or patients presenting with atypical chest pains. Probably we do not know as of today that we are dealing with subclinical magnesium deficiency in such patients. So I think practically these are the important areas where we need to consider magnesium supplements in all our patients.
Let me add here.
Yes, sir.
Manohar,
Yes, sir.
you had a pertinent question. Whom should you give magnesium?
Yes.
Time has come. You have to think whom you should not give. Otherwise, everybody should be given magnesium.
Absolutely. So we all start with some negative reasons. When vitamin D came up, also we were thinking, why should we supplement everyone? And we took some time to learn that it is really important. I think slowly that also would happen with magnesium, and we all end up having magnesium ourselves. Already, I'm having vitamin D. I think Dr. Faraz also had his own personal experience with his own family member having an issue which got corrected. The restless leg syndrome got corrected only after sustained magnesium correction. So there are a lot of such instances. Everything can't be put in the guidelines because someone here in the questions, sir, they have asked, what is the duration of supplementation of magnesium in a pre-diabetic or a diabetic? So how do we answer this question now?
Very simple. What is the duration you should breathe?
Absolutely. Okay.
That's it.
Okay. Dr. Daria, you what a beautiful point. We always thought poor compliance to be the reason between for hypovitamin D not being corrected. And also you said that vitamin D and magnesium each begets the other. So we need to have in concurrence to have a benefit to the people. And I almost heard you saying that you almost supplement everyone with vitamin D deficiency, magnesium too. Is it that standard practice what you're doing?
So right now, no, people are not using magnesium as including with vitamin D. But people started nowadays because now a combination you can get the magnesium along with the vitamin D, and that is a super combination by by giving that one. Because if you are giving alone, sorry, if you are giving alone only the vitamin D, then it may aggravate the subclinical magnesium deficiency. So if you are not giving that, so ideally that should be given along with that one. So now people have started because a few of the pharmas are coming back with both the combination, and that is a good thing.
Excellent. And also, Dr. Kedia showed some of the diuretics, metformin, which are all almost essential ingredients in the diabetes prescriptions. So they also increase or worsen the, if not the true hypomagnesemia, subclinical hypomagnesemia. I think that also calls for supplementation of magnesium in such instances also.
I'd just like to add one other important point. We often forget long-term PPIs.
Yes,
PPIs are another important drugs which can lead to hypomagnesemia. The other second category of people where we should think of hypomagnesemia as people on chronic alcoholism. They
yes.
tend to have a lot of magnesium wasting, which is often under recognized. So these are the two categories of people where again, magnesium deficiency should be always thought of.
Excellent points, I think. So hypermagnesemia, hypervitaminosis D also comes up. We have hardly seen any case like that, but always it is better to enlighten our delegates. When should we be worried about hypermagnesemia?
I will just give one pointer.
Yes,
I'll
sir.
allow my friends to speak again. The time your normal person, diabetic, hypertensive, starts having low blood pressure, think of hypermagnesemia.
Okay.
Without any reason. I'm not taking much drugs, sir. I'm not a hypertensive. I'm a normotensive. Suddenly my blood pressure is dropping. Think of hypermagnesemia. And it can only happen with overzealous, people who think Dr. Shekhar has said, Dr. Kedia has said, Dr. Daria has said, we should take a lot of magnesium because the therapeutic window is very narrow there.
Yeah. So if I look at the literature, what
It
they
goes
say,
beyond that a little.
yeah, sorry.
Go
So
ahead.
if I
Go
look at
ahead. Go ahead.
the only in renal failure patients, this is common, if at all, if it happens. Otherwise, also it's a very rare entity. And as Sir mentioned, hypotension, nausea, loss of reflexes are the one which should point us towards hypermagnesemia.
See, you know the story of vitamin D in America. Till then, unless you are in North Pole, nobody thought of vitamin D toxicity. Halibut toxicity, halibut fish, etc. Nobody thought about it. But in America, overzealous people, over the counter, vitamin D toxicity is happening, where the range is much larger. But with magnesium, it's narrower. So this is one red herring or red flag that you should tell your people about.
True. So, Mr. Arvind, are there any other points to be discussed or asked? Daria ji, please go ahead.
Sekhar sir, sometimes once you the fellow friends from the primary health centers, so they come up with a query that sir, if we are giving a magnesium in a overdose or something like that, so what they, because they don't know the exact mechanism how it works, so they are asking, see what happens with the cardiac activity because it acts on the cardiac muscles. So is there any chances to getting after taking the
Chance of what? Heart failure? He's cut off.
I think he was talking about arrhythmias.
I don't get it really. See, you remember IV magnesium? There are 3 places you've been using it there
Yes.
for ages now. So hypermagnesemia leading to severe arrhythmias, I don't really seriously think about. But blood pressure, older person gets up or she gets up, suddenly drops. They can break their bones because of this particular thing. So in a primary care, the biggest deterrent in so-called magnesium supplementation is when you are in a village setup, tell them to eat almonds, tell them to eat a lot of green leafy vegetables and all that. They cannot afford it. So I feel the so-called dietary over-supplementation may not happen unless the patient is extremely worried. The over-supplementation can probably happen with the so-called oral supplements. But
Yes.
fortunately, none of us are going to give them 4 capsules or 4 tablets or something, even one. And you should remember it's just simple replacement.
True.
That's the way I look at it.
If there are no questions anymore, I would like to request our panelist to.
So,
Yes, sir.
Dr. Manohar, the time is 9:30. I think all are pressed for time, and we were quite on time on dot. And it was a great discussion, Doctor. Thank you for the moderation. Thank you, Dr. Shekhar, for your insights. Dr. Pratap and Dr. Faraz are not there. They had something important to attend to. We thank them. Dr. Arun Kedia and Dr. Daria, we thank you for your expert insights. We had a great audience and great questions going on. Furthermore, doctor, we have recorded this session via YouTube to all the doctors. We registered doctors will be sending it through the email ID. And Dr. Manohar, I'll be getting back on any other queries which could not be answered here. We will get those queries to you and get it answered. So we thank everybody for taking time to participate in the Science and Evidence Forwarding webinar. It's been great for us to host this webinar. And Dr. Manohar, this is not going to be one-off webinar. It's going to be a series which we are going to start. And we thank you again. And thank you, doctors.
Thank you. Thank you.
Jai Shri Gurudev, good
Happy
night.
weekend. Thank you,
Yep.
sir.
Thank you. Happy weekend.